Good afternoon out there, everyone. Dr. Tony Brown coming to you with another edition of Clinical Pearls and Profits. So welcome. Today we're going to talk about the topic of adrenal fatigue. Adrenal fatigue. So regarding adrenal fatigue, this is probably something that your patients have walked in a couple of times with. Excuse me. So we know that they typically complain about certain things, right? Doc, I feel fatigued. I feel weak. I have no energy. A lot of melees. Maybe there's some muscle weakness, some different changes in their sleep patterns. So what I want to say from the very beginning is that when we talk about adrenal fatigue, if this is something that you're trying to get reimbursement for, it's not a recognized disease process. However, hope isn't lost, because what we can do is we can find in the differential diagnoses other differential diagnoses that may account for this. For instance, adrenal insufficiency. Okay, the idea of adrenal fatigue is that it's a term applied to a collection of non-specific symptoms such as body aches, fatigue, nervousness, sleep disturbances, digestive problems. Lots of things that might have those kinds of presentations, right? We've just said presents with fatigue, you have these body aches, unexplained weight loss. If I just stop right there, if you take the first and the second one, one of the differential diagnoses that you would be thinking about is hypothyroidism. Hypothyroidism, right? Fatigue, unexplained, unexplained weight loss would be the hyper, and then other signs for the hypo, but either way, a problem with your thyroid. Hypo for the low blood pressure, loss of body hair, skin discoloration. But these are some of the things that you want to watch when they walk in the door, especially the hyperpigmentation, right? Another differential diagnosis for that might have to do with Cushing's disease or Cushing syndrome, right? Hypercortisolism. So according to the theory, the adrenal fatigue diagnosis is a mild form of insufficiency, which is caused by chronic stress. And the idea is that your adrenal glands just can't keep pace with how you live your life. Remember that the adrenal glands' job in life is to put out stress hormones and counter-regulatory hormones. That is to say, stress hormones are things that when your body's under stress, whether you're running from the proverbial dinosaur, which may actually be your boss at work, right? Or when you are stressed, or when you're hungry, or when you're cold, right? All of those are situations where your adrenal gland knows that it's its job to put out things that create glucose, gluconeogenic substances. Cortisol is one of them, right? Your adrenal gland makes cortisol, which helps to increase the amount of glucose. Your pancreas puts out glucagon, which wants to put more glucose into your blood plasma. Your adrenal gland puts out norepinephrine, puts out epinephrine, all of these things to give you energy. Well, the theory here is that if you stay in a fight or flight mode, you basically jeopardize your adrenal gland's ability to do its job as nonstop as you are doing your job. And as a result, it just can't make the hormones that you're depending on it to make. A couple of differential diagnoses are depression, right? That one entitles a change in appetite, a change in your concentration, a change in your feeling. You feel tired. You don't want to go out with your friends anymore. It's worth a differential, right? Sleep apnea. Maybe they feel tired and fatigued because they're not getting enough sleep at night, right? I had a patient about 6 months ago who was put on a sleep study, one of those portable sleep studies that you bring home, and it was determined that he was waking up 79 times per hour. That's more than once a minute, right? Waking up that many times means you never really make it down to that deep wave delta sleep where you dream. You wake up unrefreshed. Sure, you've been laying in the bed for 8 hours, but you weren't sleeping. Fibromyalgia, let's not open that can of worms except to say that it may be the case that adrenal fatigue needs to travel the same road of verification that fibromyalgia did, right? It wasn't that long ago that people didn't believe in it as a bona fide diagnosis. And then the one that I'm going to speak about today is to talk about adrenal fatigue in the context of adrenal insufficiency. So what you guys want to think about is, what weapon will you use, right? One of the best weapons I like to use when I might have hormone, might have neurotransmitter things going on, is the platinum panel. So with regards to the platinum panel, it's got a couple of different sections. Of course, the first one that you really care about is going to be chemistries. Now, thyroid hormone is one of them. So let's talk a little about that. You guys spend a lot of time doing thyroid hormones. So TSH, T4, T3, reverse T3. With regard to thyroid hormones, two big points I want to make. What you're used to thinking about is that when I see a low TSH, I should probably start looking for a high T3, T4. Right? This is what you think about with hyperthyroidism. And then the other one's the other one. You probably say to yourself, if I see a high TSH, then I know to start looking for a low T3, T4. And I want to say that if you are diagnosing your patients with that very strict textbook mentality, one of the things you're going to miss is a couple of hypothyroid patients. The other thing is, it will baffle you as to some of the lab results that you get, because they will appear that they're mixed when they're really not. No problem, give us a call. That's why we're here, right? Ring myself, Dr. Brown, Dr. Bentley, Dr. Patel. But this is what I mean. It is entirely possible to have a patient with, hold on, let me get something to write with, and not uncommon, right? I'm not giving you some red herring. To have a patient with a TSH that is high, a T4 that is low, and here we go, a normal T3. I know, I hear you. I hear somebody out there saying, what does that even mean? Right? So the idea here is, I want to encourage you to, instead of looking at TSH and saying that your TSH influences your T3, T4, I want to encourage you to think about TSH primarily influencing your T4, indirectly your T3, right? And here's why. Because if this is our thyroid gland, A thyroid gland is responsible primarily for making T4. Okay, so it makes an awful lot of T4. Now, does it make T3? Well, you bet it does. We'll just put a little dashed line for that. It does make some T3. But for the most part, if the body needs T3, it makes it out of T4, right? It will take this T4 and then pluck off of it an iodide. Now it's only got 3. Now it is T3. That's how the body makes its T3 out of T4. So what did we just say? If you've got a situation where you have increased TSH and therefore decreased T4, even though your body has decreased T4 here, since T3 has a shorter half-life than T4, guys, the body's going to do everything it can to keep the T3 at a high level, because that's what it wants. That's its first choice of fuel. T4 was just a pre-fuel. That's just how you delivered it. It got delivered in the truck that way to the rest of the body, right? Centrally, you make T4. Peripherally, you use 5-iodinase enzyme to pluck off that iodide, and now you can really use the thyroid hormone. So the body will do what the body will do. Life will out. It will say, I will get my T3 from wherever I need to get it. That's going to be the T4, which means it's going to keep your T4 low. And as long as your T4 is low, your TSH stays high. But you can have a perfectly normal T3. Okay, so that's point number 1 I want to make about that. Point number 2 is that I get it. You know, you're just thinking, person walks in, adrenal fatigue, I am differentially diagnosing with adrenal insufficiency and maybe hypothyroidism. I draw some labs. Please help me how to interpret them. Give us a call. Then after you draw them, you still got to do some more interpretation, right? Because you need to be able to manage your treatment. So let's talk about a short case on managing the treatment of hypothyroidism. Let's take a look at this case. A 43-year-old woman comes to the office due to increasing fatigue and weight gain despite decreased food intake. She states, I have not been feeling well, or not been feeling myself lately. The patient asked to be referred to a dermatologist as she has always had nice skin that has now become dry. Her hair has been thinning and she hopes that a dermatologist can help with that too. Laboratory evaluation shows a high TSH, ding, 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 low T3, and low T4. So she's hypothyroid, right? The patient has a family member with fatigue whose energy levels increased after T3 supplementation. And she asked you to try this medication. Administering this therapy would most likely result in which of the following hormone level changes in this patient? All right. I promise not to call out your name if you promise to at least guess. How's that for a deal? So remember, we've got decreased T3, decreased T4, increased TSH. Your patient's chiming in on how they want to be treated. They say they're full partners in this deal because it's their body and they've been living in it for 37 years. After you treat them with this T3, what do you expect to see on your next lab result? Give you a minute to think about it. All righty, I see you. Won't call your name. And George says, call my name. Okay, so here we go. Let's think about it. First of all, I want to say that it doesn't matter how your lab reports give the numbers. Don't take it the way they give it, guys. Have a mechanism in your head. I have a mechanistic movie in my head about everything I know. It's just the way my crazy brain works. But once I've got my movie down, I don't even want to hear anyone else's movie. I've got mine down. It works for me. And I'm going to think through it. It may take me a little longer than you, but I'm going to get there with the right answer, I hope. So the movie here, I always start my movie from whatever it is that's being asked about. In this patient, we gave T3. So I'm going to start there. That's the easiest thing to think about. If I gave some T3, at the very minimum, I know my T3 is going to increase. So I can't really cross anything out with that because all of these are increased. So, right, they're in our heads. They know which way we're coming. So I think my T3 is going to be up when I give T3. Cool beans. Now that my T3 is up, I've got to figure out, well, what's going to happen to my TSH? Well, when my TSH sees T3 or T4 go up, it's going to go down. You already know that. It's going to say, hey, you gave me some exogenous T3. I'm just going to not make as much endogenous. So when my T3 went up with a drug, my TSH is going to go down. Oh, now we're getting somewhere. Now I can cross out A and B. When my TSH goes down, what did we just say in the last problem? TSH determines your T4. So if my TSH goes down, then my T4 must go down. Now we've gotten rid of echo. Now it's all down to this right here. What in the world is going to happen to my reverse T3? Does it make sense to you if I say reverse T3 is made from T4? Just like T3 is made from T4. So reverse T3 made from T4, if there is less T4, then there's going to be less T3 reverse. That leaves us with delta as the answer. What did we just say? Your hypothyroid patient comes in. You have treated them with exogenous T3. Don't be surprised if their labs show up as increased TSH, decreased T4, normal T3. Okay. Then you treat them with T3. And this is what their labs would look like. Increased T3, decreased TSH, decreased T4, and decreased reverse T3. Right, this helps you think about what you do and what you don't want to use. There's lots of different drugs that you can use to treat hyper and hypothyroidism. This would help you anticipate what you're going to do to their entire blood panel. Okay, and give us a ring. We can talk about other drugs that you might use, other non-pharmaceutical formulations that you might use. Okay, back to this idea of differential diagnoses for adrenal insufficiency. Another test that you might want to order to help you differentiate is going to be glucose. Why? Hypoglycemia can make you feel like hypothyroid, can make you feel like adrenal fatigue. They all make you feel blah. Insulin resistance, same thing. Checking C-peptide levels. Why? Well, if your body is metabolizing a lot of natural insulin, it's going to have C-peptide levels that correlate with that. The more natural insulin you burn, the more C-peptide that's left over. If there's some problem going on with the long or short or medium acting insulin that your patient might be taking as a diabetic, you'll know that because whatever insulin you're measuring is not going to have C-peptide as a leftover. Iron deficiency. With iron deficiency, of course, you feel fatigue. Less iron, you can't make hemoglobin. Less hemoglobin, you can't bind oxygen. Less oxygen, you feel tired. That said, there's more reasons that iron might play into your patient's feeling fatigued. Infection is one of them. The body has a way of when a bacteria comes to infect it, it remembers that bacteria love to munch on iron. So what it does is it takes the iron, connected to some stuff called transferrin, which shuttles the iron away into the bone marrow and locks it away in the macrophages. Whoop-dee-doo that you hid that iron away from the bacteria. Boo that you hid the iron away from yourself, and you end up becoming iron deficiency anemic. All of these others, this ferritin, it's a good lab to draw because it'll tell you just how many of those shuttles are filled with iron. If they're filled with iron, it's because they're getting ready to take it back to the macrophage. Total iron binding capacity basically tell you how many seats are left on those shuttles, right? If the seats are empty, it's because they're not getting ready to move the iron back to the bone marrow. That's good. If the seats are filled, if the total capacity left is 0, it's because all the seats are filled on the way to the bone marrow. Iron saturation is an expression. It's just a different, actually, you know what? It's a different way of saying the same thing that I just talked about. C-reactive protein, as you know, that along with erythrocyte sedimentation rate are general markers of inflammation. Well, as I just said, you could have an infection. Well, there could be inflammation-related infection. And then the rest of the story you know, because it just gave you the mechanism for that. And then finally for today, a kidney problem. What in the world would a kidney problem have to do with fatigue? Well, remember, first of all, that BUN and creatinine, the higher the numbers, we're measuring the serum, the higher the numbers, the worse the kidney is working. If you get high BUN creatinine ratio numbers in your blood plasma, it's a sign of a failing kidney. A failing kidney is not a good thing because your kidney is also responsible for making erythropoietin, which makes red blood cells. Fewer red blood cells, fewer hemoglobin, fewer oxygen, less oxygen, you feel tired. Also, your kidney is responsible for activating your inactive vitamin D. Vitamin D has the job of increasing your calcium absorption. Calcium has the job of kicking off a lot of enzymes in your body. You don't want to be hypocalcemic calcemic. You got all kinds of problem, muscle contraction, and just enzymes in general. You did it one more time, guys. Wasted a half hour of your life nerding out with me about this stuff. I do appreciate it. Hopefully it was helpful. Send an email if you want to chat about labs and nerd out about your particular problem patient. Just send an email to info@virtualclinic.md and ask for a consult. info@virtualclinic.md. That's all I got. Have a great day out there, guys. Bye-bye.